Today I have the pleasure of introducing our Grand Round speaker, Dr. Andrew Wang from the University of Virginia. So Andy is no stranger to New York. He received his undergraduate degree from Columbia and then earned his medical degree from the University of Virginia. He completed his internal medicine residency at Northwestern, and then after that he came back east for GI fellowship training at the University of Pennsylvania. Upon completion of his categorical fellowship, Andy returned to the University of Virginia for advanced endoscopy training, after which he's been on the faculty since. He has risen to the ranks of full professor of medicine and is the section chief for interventional endoscopy. I can go on and on about Andy's accomplishments. He has innumerable academic achievements. To list a few, he is the chair of the AGA Clinical Practice Updates Committee. He's on the editorial board for the journal Gastroenterology. He's an editorial review board for GIE and Video GIE. He's a member of the DDW Executive Planning Committee. He is the consummate educator. He is the director of their Advanced Endoscopy Fellowship. He's mentored countless fellows, residents, and students, and has received multiple teaching awards. But more importantly, Andy is an international authority on a wide variety of topics in interventional endoscopy. He can really give us grand rounds on anything. And he's published widely on a number of topics, including natural history of gastric intestinal metaplasia and early gastric cancer, prevention of pancreatitis, endoscopic resection techniques, including ESD for GI malignancies, and a variety of topics on Ercp. Andy has had the good fortune to both train and work at a center with extensive experience in the endoscopic management of bile duct cancers. So today he is going to give us an update on the diagnosis and management of cholangiocarcinoma, and he's going to share his extensive experience on the use of endoscopic ablative techniques to treat these difficult tumors. I have known Andy for as long as I've been a gastroenterologist, and I always learn something after I hear him speak. So I am excited to welcome my friend to Mount Sinai and New York to speak to us today. So I'll turn it over to you, Andy.
Can you guys hear me okay? Chris, thank you for that really humbling and outstanding introduction. Every night when I tuck my girls into bed, we have this routine, and I tell them I love them, and they say I love you more. Everything you said about me is true about you, and thank you. I wanted to say thank you to friends and colleagues. Thank you to the GI chiefs, Yakira and Zoe, for coordinating this. Bruce was an endowed lecturer down here. I gave the Respis lecture, and it's great to see him, and David, and a lot of familiar faces. Satish and I have overlapped in training over the years, and so you guys have a great institution. To the advanced endoscopy fellows out there, I would highly recommend you ranking Mount Sinai first. I have no dog in the race. We're not accepting an advanced fellow this year, so this is my unvarnished opinion. But I really do think the training there is outstanding, as evidenced by what you've just seen. I'd like to give a shout out to Ross Berline. Ross is our advanced endoscopy fellow, and he's joining me on faculty as an assistant professor in advanced endoscopy soon. You'll see a lot of Ross's data in this, and if I get any hard questions, I'm going to tag Ross to answer them. So let me share my screen here. Can you guys see the screen?
Yes, looks good.
Okay. So yeah, I'm happy to be here talking about cholangiocarcinoma. I'm going to touch on some of the basic aspects and then focus on endoscopic ablation therapy. I have no disclosures. So I'm privy to have this picture. I don't know how I got it, probably through ASG leadership. Term it the GI, ACG, ASGE Avengers. And, I'm a fellow of both societies, and, there's great camaraderie. And, I didn't group this picture, and, these are luminaries in the field, of course, current and past ACG, ASG presidents. I did not actually order them, and so I'm not going to assign superhero characteristics to any one of them, but I really don't think that Captain America has anything on these three guys. moving forward, keeping a little more real, this is our leader, Chris, and the group call us the Interventional Endoscopy Avengers, sharing a beer at the WashUt course. And hopefully we're not in need of an intervention yet. So like Chris shared, you know, I have some roots from New York. I spent my undergrad days there and I really loved it. I was a member of the Columbia Area Volunteer Ambulance Corps. And things are pretty quiet when you're an ambulance driver or a medic for a college. So we would go trolling the Upper West Side and as far down as Mount Sinai for interesting things. And I've always had a lot of respect for Mount Sinai. In fact, when I was looking for med schools, I was accepted there among a few other places. And I really had my heart set on going, but I think UVA had a great reputation, and being a Virginia resident, it was, you know, super cost effective. So, but I still have a fond spot in my heart for it. When I was interviewing, I think the Guggenheim Pavilion had only been out a couple of years, and you know, for New York, where skyscrapers are like townhouses, I think a building, you know, designed by Ampey where you get light in every patient room is just fantastic. So, you guys have a great place. Focusing on the talk here, cholangiocarcinoma, as you guys know, is a malignancy of biliary epithelial cells. It's termed as extrahepatic perihilar. Perihilar, 60 to 70% of them are perihilar, and this is where you get the term Klatskin's tumor. And then there are intrahepatic cholangios, which may be biologically a little distinct. We're going to focus on perihilar cholangiocarcinoma for this talk. Of course, cholangiocarcinoma has a high mortality because a lot of these patients present with advanced disease. Those who can get surgery may have cure up to 60% of the time, but really most patients come too late, and the 5-year survival is about 5 to 10%, with median survival really numbered in a few months. About 6 months is a lot of times what we see. On the left, this is an example of an extrahepatic cholangio, pretty rare, can look like pancreas cancer. This was a young man, 45, with PSC. In the middle is a little bit more what you expect. You can see actually the left hepatic duct here in this lower arrow and the right, and so this takes out the hilum. And in this right panel, this is the confluence right here of the left and right hepatic ducts. And this is in a higher order right hepatic branch, so this is intrahepatic. The Bismuth-Corlett classification has been useful, and I'll go through it briefly. This is for perihilar cholangios alone, okay? So if you actually have one that extends up to the confluence in the common hepatic duct, that's a type 1. Type 2 is where it actually gets into the takeoff, or maybe where the confluence merges, however you look at it, of the left and right hepatic ducts, but not to the first order radicals. Type 3A is when it gets into the right duct to the radicals, and this is on the right side, 3A. 3B is the same on the left, and a 4 is a bilateral disease. So this is a question from the AGA DDCEP, which I was fortunate to be a reviewer and editor of. 52-year-old man with history of PSC found to have rising liver-associated enzymes, undergoes MRI, found to have a new irregular hilar mass and intrahepatic ductal dilation. The labs are, as you see here, bilirubin of 8, ALT, AST in the hundreds. The CA19-9 is 900. No evidence of metastatic disease on cross-sectional imaging of chest, abdomen, and pelvis. Representative images here, you can see markedly dilated ducts on both sides and an enhancing mass in the hilum. This is the corresponding MRCP. So which of these should be avoided in this patient? Percutaneous biopsy of the hilar mass, EUS for FNB or FNA of any lymph nodes, surgical laparoscopy, Ercp with cholangioscopy, or referral to a tertiary center for transplantation consideration. So it's hard to do this over Zoom. If the chiefs want to call on someone, I'll accept any answers. And I'll also pause and just go on here. But so the right answer here is actually A. Percutaneous biopsy of the hilar mass should be avoided. There are data, I wouldn't say they're high level data, but there are data that's showing risk of seeding. And if you actually seed, in this case, in the peritoneum or lymph nodes, you can obviate the possibility of liver transplantation. which is done in certain centers. The other options are actually fair in terms of EUS for lymph nodes. If you find a positive lymph node, that patient is not a candidate for transplantation. Laparoscopy is sometimes done prior to transplantation. Ercp, of course, we'll talk about, and referral for higher level care for these complex perihilar strictures is appropriate. So this on the left is an example of an ERCP in this patient. You can see it really corresponds to the MRCP. And on the right here is a digital cholangioscopic image. You can see polypoid fish-like protuberances and friability denoting cancer. So for a long time now, it's been a question, what's the best diagnostic modality via ERCP? And for David in the ACG, I'm actually helping Joe Munzer write a guideline. So we reviewed about 1,400 papers on topic of biliary strictures, and there are tons and tons on the best diagnostic modality. When you're talking about endoscopic sampling, it's important to note we want something with high sensitivity, so you have few false negatives, perfect specificity, so you have no false positives. So this is actually from a surgical resection, and you can really see the fine details of the tumor, very minute extension in millimeters, but there is extension. We're really not here at endoscopically, but what do we have? So brushing, I'm not going to show you a video of, that's pretty commonplace. Over a wire, you can put in a cytology brush and brush a stricture. This is an example of a particle forceps biopsy. Typically after sphincterotomy, you put in a forceps pediatric or standard, and this can be dangerous, so really has to be done by someone with expertise, but you can actually get particles in tissue. This is an example of fiber optic cholangioscopy, which we used to do for many years until about, I think it was about four or five ago. You can see here in this patient with cholangiocarcinoma, similar polypoid tumor with friability. Now, in this current day and age, we have digital cholangioscopy, and the image quality, of course, is much better, similar to what I showed you in that prior picture, kind of fish-like polypoid tissue. You'll see as we pull back a little bit, there's some more friability, there's bleeding. This is all signs of cancer. Might be similar to what you see in a colon or esophagus. Here we can do cholangioscopy-directed biopsies. And as we pull back, you can kind of see it more. So a little bit of data on this. These data are from Peter Dragunov, and this is from almost 10 years ago now, where he's looking at cytology versus standard biopsies and mini forceps biopsies. And as you can see here at the bottom, cytology actually has really poor sensitivity. Most people quote in the 25% range. Here in Peter's study, it was 6%. As you will note, all of these diagnostic modalities have high specificity. So if you diagnose cancer, it's invariably true. But even the particle biopsies, which I showed you an ideal example, is only about 30% sensitive. However, when you do directed, visually directed cholangioscopic biopsies, the sensitivity may increase up to 80%. This is a little bit high, I think, for the broader data, but it's still better. You can see it's better than the alternatives. So some newer advancements, if you can actually direct say a nasal endoscope into the bile duct, which is I found possible in about maybe 30 to 60% of cases, depending on the anatomy, you can actually conduct narrowband imaging. This is a study from our friend Sachin Wani and colleagues, and they actually found that combining the visual impression with this kind of tissue sampling was highly sensitive and specific. But if you actually take a step back, their visual impression alone was about as sensitive and specific. So the pretest probability here and what you see clinically really does inform a lot of what we get on the other end. EUS, intraductal EUS is still done widely in Asia for this, but in the US, we don't do this as much. However, standard conventional EUS has been used, and often you may not see a mass. If you do, of course, in the extrahepatic area, you can biopsy it. But thickness of the bile duct wall has been a surrogate for tumor. And so I use, like Jeff Lee published here, 3 millimeters as a cutoff. If you have thicker than a 3 millimeter bile duct wall, it's actually pretty sensitive and specific for malignancy. Introductory US I talked about, it can be highly sensitive. Here it's almost like looking at a mass in the esophagus. But like I said, it's these probes are prone to breaking over the elevator, and most of us don't really do this much. Second generation OCT is now available, and in specialized centers, there's some experience. I must say it's really, I don't think, hit the corner mom and pop shop, and it's not really widely used, but you can see very detailed levels like you might see in the esophagus where you have polypoid tissue and tumor invasion. Biliary confocal endomicroscopy is also out, and these are images from a normal patient. I must say this is, I have a fellow used to call EUS kind of looking at like shadows and shadows and salt and pepper, and this is probably even worse. But here you can see kind of these dark irregular structures. Bright areas denote abnormal vascularity, and this is an example of cancer. So it is very operator dependent what you're looking at, and also highly, it's in my opinion difficult to use, but it has some utility. FISH is a modality that's been around for some time, and some places reflexively test for it, but it's not available widely. And here we're trying to augment brush cytology by looking at polysomy and at the chromosome level. So each cell should have 2 similarly colored chromosomes. If there's more than 2, that's an example of polysomy and mutations and malignancy. FISH has actually evolved on to look at different probes, and this is a paper from Gastro from about 5 to 6 years ago. But just to let you know that there are now more sensitive probes, but again, this is not widely available. So really in 2021, I think we're still at where we were about 10 years ago. I think multimodality sampling by whatever means you have available, brush, biopsy, single operative cholangioscopy, still the way to go. Reserve EUS, FNA, FNB for extrahepatic masses, sampling of lymph nodes in patients with perihilar masses, and direct sampling of unresectable or non-transplantable perihilar masses. So to kind of switch gears a little bit more into therapy, people with cholangiocarcinoma die eventually, typically from biliary sepsis, from blood clots, liver failure, sometimes hemorrhage. Where we can intervene is from the perspective of drainage, and typically Ercp. Ablative therapies is something that we're going to focus on, and I think in the past 10 years or so really has, there's emerging data to show its place. So just to talk about the liver, our surgical colleagues really know all the segments well. Really for us, I think it's important to divide the liver into 3 portions. You have the left liver, segments 2 and 3, the right liver, the intermedial segments 5 and 8, and the posterior lateral 6 and 7. If you really think about it in sectors, I think it helps you. You really don't need to know what's on the backside, where 4A, 4B are. But when you're thinking about drainage, there's always been this debate about right side, left side, bilateral. I think the evolving thought, though, is that if we take the liver in sectors, thinking that each sector has about 1/3 of the volume, you really want to get more than 50% drainage. So that usually requires 2 sectors. This sometimes can be done with 1 stent if you have a bismuth 1 tumor, but sometimes you may need 2 or 3 different stents. So just think about this. It's important not to opacify or even count atrophic lobes. And so pre-planning imaging is important, but this I think can really guide us in our drainage. So in the approach to treatment of patients with perihilar cholangio, operative resection of course would be the way to go. For patients with bismuth 3A and B lesions, it's either a right or left hepatectomy. If you have a bismuth 1, you may need a Whipple, or 2, a hepatojejunostomy. it's important to look at the vascular involvement, even though, let's say if you have a left-sided perihilar cholangio, but there is right-sided vascular involvement of the artery or vein, that's not resectable. And so in this day and age, it's very common to get liver volumes. And for tough cases where you might have, say, a bismuth 3A tumor, and you want to actually, the surgeon wants to take out the right liver, the left liver may be too small to support that patient afterwards. And so they may do things like selective portal vein embolization of the right side to kind of hypertrophy the left liver. However, in this setting, it's important to maintain the left liver so it doesn't get atrophic. So although the left liver is not affected, we often do stent the left liver. So that's actually an important concept. Transplantation is important, and really these are kind of the basic things that you need. You need to see a mass or have a malignant appearing biliary stricture with an elevated CA19-9 or positive or suspicious breast cytology. Palliation, I think this is where we're going to also go with in terms of the talk. So I think it's important to know that our interventional radiology colleagues are also very good at getting at these strictures. And if you read Peter Cotton's writing in, I think, GIE about the complexity of ERCP, perihilar stenting is a fairly complex type of ERCP. And that's actually the underpinning for why a lot of these studies have heterogeneity or different kind of outcomes. But if you look at PTBD, this is from a standard and practice update from the IR journal, Vascular IR. This is from 10 years ago, but the death rates reported from PTBD are almost 2%. And so, you know, they suggest a quality threshold of 3%. And that would be astronomical, I think, for ERCP. And in this study published not too long ago out of Lancet, a randomized study, it was prematurely closed because there was actually higher mortality in patients who were randomized with perihilar cholangio to PTBD over ERCP. So we actually tried to further investigate this using Joel Munzer's US Core Cooperative Group. And we were fortunate to be a part of this study. Unfortunately, we had to close it because really there was not appropriate enrollment, but we sought to randomize patients to PTBD versus ERCP. As you can see, just from the limited data we reported in CGH, the groups were pretty evenly matched. But if you see here, actually at the bottom, death within 3 months numerically seemed to be a little more frequent in the PTBD group, but really, you know, we're not powered to show a significance. So I think the question's still out. We talked about choice of stenting in patients with unresectable biliary malignancy a little bit, and the complex nature of perihilar stenting. You know, I'm not going to go into bilateral metal stenting, Y stenting, side-by-side stenting, and there is great debate actually whether or not if you find one of these patients, you should just leave an uncovered metal stent, or if you should place plastic stents. Oftentimes we place plastic stents first because the diagnosis is uncertain, and we've all seen patients with these metal stents and either they're cured from their cancer or maybe it wasn't cancer in the first place, and that's a disaster. But sometimes it's pretty clear they have metastatic perihilar cholangio. And, you know, I think it's not wrong to place a uncovered metal stent. This study was from the Cleveland Clinic, and Sunguk Jang and colleagues published it, and it's still in press in CGH. They actually showed that for extrahepatic malignancies, including cholangios, metal stenting was superior across the board. But if you kind of drill down into the data looking at perihilar disease, you actually find that plastic stenting with respect to time to unplanned interventions was a lot inferior to metal stenting. But when you look at the occlusion rates for hilar disease, actually there was much more occlusion with metal stenting for perihilar malignancy. And they thought this was because the metal stents kept them alive longer so they could capture more adverse events. But be it as it may, I think it's difficult to place metal stents in perihilar disease. And sometimes by placing them, we can actually impede our ability to get back. So in my opinion, I think the jury's still out, and I'll kind of tell you how we look at it. Going on into the therapy, Brachytherapy has been around a long time, and our radiology colleagues, usually via PTBD with radiation oncology, can do this pretty easily, but it's also possible to do endoscopically. Todd Barron, before he left Mayo, had probably the US's largest experience in this. Brachytherapy has been shown to be efficacious in terms of survival, although there are some mixed results. Improved stent patency, similar. Because of some of these limited results, the Mayo Clinic, last when I spoke to Todd a couple years ago, had adopted high dose rate brachytherapy, which is a more intense kind of therapy. Of course, brachytherapy is tough because these are iridium laced nylon ribbons that you can put through a nasobiliary stent or a percutaneous bile duct drain, or even through a stent that you can deploy via Ercp in a special method. But it exposes the team to radiation. There are reports of higher rates of cholangitis, hemophilia, and actually radiation damage to the viscous organs, the duodenum and the stomach. So really, although brachytherapy is done, it's difficult. And this is an example of how you can see these iridium-lined strings inside of these stents here going across both the right and left sides. So photodynamic therapy then is an alternative strategy to treating these patients. PDT uses an intravenous photosensitizer, which when activated induces tissue necrosis and apoptosis via oxygen-free radicals. So the photosensitizer we have is porphyrin sodium. This is FDA approved for use in the lung and esophagus, but not for cholangiocarcinoma, despite the data. There are second and third generation photosensitizers like tempraporphyrin and others, but they're not really available for use for us in the US. So PDT has a couple of mechanisms of efficacy. The reactive oxygen species, like I told you, can ablate or kill tumor cells directly. PDT damages tumor-associated vessels, and this may lead to infarction. PDT also stimulates an immune response against tumor cells, and it's been known that PDT probably is preferentially taken up by tumor cells. In animal models, there is actually some data to support an enhanced immune response. So when you actually do an endobiliary PDT, patients infused with the non-FDA approved porphyrin about 2 to 3 days is the maximum window before ERCP. Then we bring them in for ERCP. And after you get infused, you actually have to be very careful. We caution the patients. They go to the cancer center, but the cancer center has to put up these thick drapes. The patients have to then wear like a ski mask and gloves on the way out. And it's pretty intense. If you actually don't take precautions, you can get a very severe burn. During ERCP, a catheter or choledocoscope is placed to the level of the stricture. The wire is removed that you use to guide your device there. A laser diffusing catheter is then placed to that level, and then activated light using the laser activates the PDT, and then you stent. This is an example of actually what the laser fiber looks like. And it's very subtle here, but this little marking dot shows you the bottom end of the treatment end of the fiber. And so we're conducting PDT in this segment. For the fellows out there, it's incredibly boring. And so as an attending, it's always important to have a fellow because it's a 12.5 minute, you just stand there holding it. And so, you could probably elicit plantar fasciitis if you're trying to PDT multiple areas. But I really do have to say, for those of you who do it, and a lot of you guys probably have experience in the past with the esophagus, this light sensitivity thing is important. As an aside, I was covering my partner, Dan Strand, and I got this page. And one of his patients, this elderly gentleman who we PDT'd, was driving home. And I think he was admitted a day afterwards, but his wife was driving and he was masked up like, in this ninja outfit with this black mask and gloves. And the poor guy, as they were going through counties in Virginia, there were these police cars that started one by one following him. And they actually thought that this person had carjacked this elderly lady. And so after a couple of counties, there was this ring of police that like drew guns on this poor little guy who had been, treated with PDT, and it's just because he looked like, he was a robber or something. But I think that level of, protection is important because, like I said, burns are possible. So in terms of survival, PDT is not FDA approved, but there is a strong body of evidence showing its efficacy in terms of survival. These are kind of keynote studies, one by Ortner from years ago in gastro, showing 10-month survival in a small RCT, with PDT and stenting being superior to stenting alone. Another one from the Red Journal in 2005 using Photosyn, which is a second, third generation hemoporphyrin derivative, showed also 14th month survival when you applied PDT and stenting versus stenting alone for perihilar disease. This is actually a patient of mine who, after 4 weeks, we tell them to cut a little hole in a sock or stocking and then just expose their hand to some sunlight for 10 minutes. And if there is a burn, you're supposed to then tell them 2 more weeks, you can't be near the sun, even at night. You have to have drapes because the reflected moonlight can be, can burn you. She actually fell asleep next to her window and developed some, pretty decent burns. And so she came to the ER for that. This is an example of when my laser fiber actually broke in the duodenum and caused burns just over about 30 seconds in the duodenum itself. So burns, we talked about. Pain and nausea and cholangitis are side effects associated with PDT. Probably the biggest drawback, and this is maybe more from a higher macroeconomic level, because most insurance, including Medicare, will pay for it, but the single dose of PDT is approximately $38,000. And this was in 2013 when we last looked at it. And so it's pretty expensive. This is an example of a patient. Here you can see the perihilar cancer stricture. Patient was stented and then treated with PDT. After subsequent stenting, actually, you can almost see resolution of the malignant stricture in this patient with PSC. So it actually pretty good effect. And this is after 15 months. So I've talked to you about some of the difficulties of PDT. And in practice, when you counsel these patients about the pros and cons and the data, a lot of them actually end up choosing RFA because of the quality of life with an incurable disease. You don't want to be holed away in the darkness for 6 weeks. And so RFA, I think, really has a place even before a lot of the data emerged. RFA uses a bipolar catheter and high-frequency alternating current. It requires direct contact by the probe with the tumor, and it provides coagulative necrosis. And in fact, it creates a full thickness burn. And so it's important to note that you must stent these patients afterwards. Percutaneous and intraoperative RFA has been shown to be actually very successful in treating patients with cholangiocarcinoma. A lot of these are actually intrahepatic, but also perihilar. But importantly, RFA is actually got a pretty wide FDA 510K approval for tissue ablation throughout the body. So it can be used for treatment of perihilar cholangio. These are the commercial available catheters. This is the Boston Scientific product, first called the Habib Endo HPB that we can get. And it's got 2 bipolar probes. In total, the ablative area is about 2.2 centimeters. So that's important to note. There is a new kit on the block now available in the US, and we're in the process of demoing it ourselves, the Alara probe out of Korea. And these are a little more customizable. There are different patterns and sizes of the RF electrodes. And so you can treat smaller or wider areas. This is an example of ERCP where you can just see the ease of how one can pass this 8 French catheter into the bile duct. There was a small papilla sphincterotomy, and it's just, if you can pass a stent or any kind of device, you can pass this device into the bile duct. So you can see that the electrodes now have entered into the bile duct. So what's the methodology for endobiliary RFA? RFA is passed again over guide wire across the stricture. We use fluoroscopy to center the bipolar rings, and remember that there's going to be a larger ablative effect. We often try to avoid the cystic duct, or we don't want to jail other areas unless you really need to. Energy is delivered at typically 10 watts for extrahepatic strictures, and we were using 10 watts for many years, but we and I think Mike Levy at Mayo actually found that there were complications when you used 10 watts across the hilum. We had a case of hemobilia from a fistula we created, and so now it's recommended to use 7 watts across the hilum or in the intrahepatic stricture disease. There are 2 applications, 90 seconds each, so much better than the 12.5 minutes used with PDT, with a 60-second rest interval. And following RFA, we sweep the duct to remove any debris before the second sometimes before the second application, but definitely after the second application. Like I said, the Boston Scientific device can actually be used with commercially available generators such as the Ercp or Olympus generators. The Korean Elara system actually requires a dedicated RF generator, but I found that actually our interventional radiology team has one, and yours may as well. And then we deploy stents. This is an example of endobiliary RFA here. This is a high-grade stricture in the common hepatic duct, treated with RFA with improvement in the luminal diameter. And in this case, we placed a uncovered metal stent. And you'll see this case arise a little later. This is actually, we all have our great cases. And this is an example of a patient of mine who actually survived over 6 years with a combination of ERCP and RFA. He was very healthy. He had a bismuth 1, but on surgery was found to be unresectable. And you can see it's interesting over time. I've noticed that the disease actually causes your bile ducts to shrink or abrogate. And he is like a 6'2" kind of tall Air Force aviator, and he had a normal bile duct that shrank down to almost nothing by the end. And so it's an interesting observation. Getting to the data a little bit here, recently there have been 2 RCTs, and I'll go over them quickly, both out of China. But in this one published in Endoscopy, they randomized 65 patients with unresectable extrahepatic. Here they actually avoided type 3 and type 4 hilar cholangios, but included the type 1 and type 2s. And they actually found overall mean survival significantly longer in the RFA and stent group, 13 versus 8 months. This is actually in Press and GIE, and it's a larger study out of China. Similarly, they excluded patients with type 4 disease, but found that in this study, there was a statistically significant survival, RFA 14 months versus 9 in patients with hilar and extrahepatic cholangio. So now emerging level 1 evidence to support this treatment. RFA here, you can see that same patient I showed you a couple slides ago came back with tumor ingrowth. And here we can be very aggressive treating the tumor ingrowth with RFA, and it works quite well. And we placed an uncovered stent within the first uncovered stent, and you can see very much increased luminal patency. This is an example of a similar case, patient where we actually had bilateral metal stenting. He came back after some time with a stricture here in the right hepatic duct, as you can see there. We first balloon dilated it because I think I had trouble getting a retrieval balloon across, and the RFA catheter is the same luminal width. And so here we're inching our RFA catheter across the stricture. Once we get it in place, we apply therapy, like I said. And then I'll show you kind of the appearance afterwards. We don't routinely look with cholecystoscopy, so the images I have are kind of from the earlier days. But you can see the tumor, and you can see here a whitish coagulum. This is the ablative effect from RFA. And so it really does cook the tumor pretty well. So looking at a little bit of our work, we actually compared a couple of years ago, Dan Strand, my partner, did this study when he was our advanced fellow, but comparing patients treated with RFA to PDT who had perihilar cholangio. And the long and the short of it is we didn't find any difference in survival. We were criticized because we didn't have a control group at that time. A lot of our patients didn't opt to actually just have stenting alone. And so a little bit about PDT versus RFA. We said RFA is less expensive, it's FDA approved, but it's a little more difficult in that it requires direct contact with the neoplastic tissue. PDT, because it's a light-based therapy, can actually treat strictures that you don't actually touch. And so it may have that added benefit. PDT at the time in the past had more robust data, but this is, I think, changing now. Of course, it's more expensive. Patients have to avoid sunlight and not FDA approved. So this is a important diagram from a very important book edited by Dr. DeMeo, which we're happy to contribute a chapter to, but this is our proposed algorithm in patients with confirmed perihilar cholangiocarcinoma. Those who can go to surgery should go to surgery after tumor board review. And those patients who are very frail, who can, really not take care of themselves, metal stenting is for sure appropriate. However, in those patients who want to pursue endobiliary therapy for survival, we do offer them either PDT or RFA. If you go down the PDT route, we often repeat it in 2 to 3 months. And if you go down the RFA route, similarly, we often repeat in 2 to 3 months. And this is a little bit vague and not well defined in the literature, but who to give plastic versus metal to. We tend to favor plastic because patients sometimes surprise you and the metal stents can over time become occluded and tough to work on. So Ross actually presented at DDW 2 years ago in person our recent data looking at a large cohort of patients with perihilar disease, only perihilar disease. So it was a homogeneous group, nearly 60 patients who underwent PDT or RFA and stenting. The main outcome of interest was survival. And jumping to the data here, we found in our predictive model that survival is actually superior in the patients who had any kind of ablation, 10 months versus 6 months. This is RFA and or PDT and stenting versus stenting alone. Similarly, when we looked at our RFA patients, which was in the majority, they had a 10-month survival versus 6.7 months, which was also significant. So our retrospective back it up. Going on for I'll take a few more minutes. I think we're getting to the 45-minute mark. We actually then have taken a step further and looked at endobiliary ablation and liver transplantation. So this is an important study out of Gastro looking at the time, the experience in the US for liver transplantation. And there were a number of centers that were using brachytherapy, 214 out of the 287 patients who had perihilar cholangio and got transplanted or were trying to be transplanted. Importantly, in subgroup analysis, they actually found that the recurrence-free survival for patients who received brachytherapy was similar to those who did not. So it wasn't clear brachytherapy was doing anything for them. So then we thought, well, gosh, can we actually use PDT or RFA? And so we modified our transplant protocol to use PDT as a neoadjuvant regional therapy. And we published years ago in the American Journal of Transplantation our first experience for patients who underwent PDT prior to protocol liver transplantation for perihilar cholangio. And we actually had very good results. All 100 patients were able to make it to liver transplantation, which was not the case in the brachytherapy groups described before. Our disease-free survival was 75% at 28 months, which is significant. We updated our data recently, and Ross is going to be working on it, but we've now, I think, got them to 8 patients, but at the time we last presented this at DDW, 7 patients with 2 RFAs. Cancer-free survival was still about 60% at a median of 33 months. So this is something we're interested in. It's hard to find patients, but it may be something to study prospectively going forward. This is from one of our explants. You can see that in this case, the PDT really obliterates the cancer. This is actually a little bit of the bile duct left, but you can see here just kind of the obliterative effect of the PDT. I'm not going to spend too much time. This is just the data. I'm happy to provide my slides to you guys later, but this last part I think is very interesting. It's something that we're interested in. We're collaborating with Kim Kelly, who is one of our biomedical engineers. And this has to do with plectin. Cell surface plectin is something that UVA has been studying, and it's only found on the surface of the cell. Plectin is only found on the surface of the cell when there's neoplasia. No normal tissues express cell surface plectin. And so this was discovered during Kim Kelly's, I think, postgraduate work up at Harvard, and she transplanted it down here. And we've used it actually as a way to identify tumor. So Kim actually found that cell surface plectin is necessary for tumor progression. In this mouse model, in those mice that were wild type, the tumor progresses, but actually when the plectin is knocked out, tumor really doesn't progress. So that's an interesting caveat in terms of therapy. When she looked at some of the tissue we had banked, cholangiocarcinoma actually has high affinity for this kind of immunohistochemistry, looking for cell surface plectin. And the pancreas does as well. The pancreas has had a little bit of a head start given just a large number of patients with pancreatic cancer. And these are actually published data showing immunohistochemistry, and plectin, cell surface plectin does stain starting with PANN3, pancreatic cancer, xenografted mouse pancreatic cancer, mets of the liver, peritoneum, and lymph nodes. Similarly, for IPMNs, we've shown similar results with cell surface plectin. And so it's pretty interesting that actually they were able to tag this scintigraphy agent to cell surface plectin and can now actually do imaging, kind of like a PET scan, using this modality. And so Ross at this moment is meeting, and we're hoping to actually look at this as a way to augment our ability to diagnose cholangio using brush cytology, which I think would really help when you talk about the diagnostic problems we've had as a field so far. And our cancer center is also looking at conducting a early phase trial in patients with refractory cholangio who have failed first-line chemoradiation. And so I think there is going to be some exciting news in the next 5 years on this front. So with that, I'm not going to go through the take-home messages. I'd rather save some time for question and answers. But I think in a nutshell, perihilar cholangio, I think, should be managed by experienced endoscopists in a multi-center fashion with IR, surgery, chemo, radiation specialists available. How we approach ERCP is evolving, and I think a sectorial approach is going to be important when we talk about drainage. Endobiliary ablative therapy, I think, is no longer the new kid, but probably should be considered as palliative treatment for all patients. And it may have a role actually in those undergoing transplantation. There's still a lot of room to work in terms of how best to stent these patients, how many ablative therapies that they might need to undergo. And hopefully Chris, I, and our friends can continue to push that envelope. So this is the important best seller and read. And I searched the New York Times hoping that it would show up on the bestseller list. I did find Chris's wedding announcement. Congrats! Looking forward to meeting Mrs. DeMeo, but I think one day. And I wanted to thank David Westaby. I actually went to London to learn RFA from him. He helped to develop it, and Paul Yaten, my mentor, actually trained me in PDT. So thank you all for your attention, and thanks for this opportunity.
Andy, you delivered on every possible way that my introduction suggested you would. So thank you for a thorough and exhaustive review of the topic. There's so much we can talk about. I want to open it up to questions from the audience. I have a few which I'll save for the end, but let's see if anyone else has Any questions?
Andy, that was a great talk. I really appreciate the expertise and excellent explanations there. We see a boatload of cholangiocarcinoma here. We have a very robust liver surgery program. And sometimes there are some weeks and months that go by that I feel like we see more cholangio than pancreas cancer, which is, I think, a little strange. And so we've bantered about and talked about getting some kind of ablative program up and running, because I mean, the data is really compelling. What are some tips you could provide about, getting a program going? What are some good things we should do, best practices? What would you advise?
Sure. I would focus first on radiofrequency ablation. I think it's commercially available, cheaper, easy to do, doesn't add time to your ERCPs. I think you guys are a huge center, and obviously there are people with experience with PDT from the esophagus, from years past. And I think it's probably important to offer that. There are some situations where you might have multifocal stricturing where PDT may be more effective, but I would say for 80% or more, I mean, RFA probably is sufficient and easy to do. And I would start there. I think a multidisciplinary approach is important. For the unresectable patients, most of the time, the surgeons and oncologists don't really care as much what we do because they're unresectable. But for the resectable ones, I think it's important to get them to surgery and to really figure out in a quick manner, who is amenable to that. And likewise, I think you guys are a big transplant center too, and I think there's a lot you could do there as well. And we'd be happy to, partner in terms of studying all this stuff. I think the Chinese have an advantage in terms of large hospitals and large number of patients who are quite compliant. But I think doing a good study looking at just perihilar disease is important. There are many editorials out of Europe calling for that. I think its time is coming. But I can see you guys starting a program very quickly and I think easily and effectively.
Well, along those lines, Andy, what is the role in patients who have local or regional lymph node disease or limited metastatic disease? You mentioned the potential immunologic effect that ablation of the primary tumor can have. Where does that fit? Where do those patients fit into your program?
Yeah, it's an awesome question. In fact, years ago, Merck had some interest in partnering with us, and we just didn't have a lot of data at the time. But with all these immune therapies, there's a great interest on these companies on $1 billion kind of money level of looking at ways to potentiate tumors to create an immune response. And interestingly, I didn't drill into the data as much, but the Chinese data have shown maybe a signal of decreased progression to metastasis in these patients. And so it's unclear how RFA actually would promote decreased metastatic rates. I mean, you ablate the local tumor, but micrometastasis ostensibly may already be there, but there may be some kind of immune effect we're not seeing. It may be hard to study. I know PDT, I told you, there is some animal models suggesting that more strongly. And, we don't have a basic science lab studying this, but perhaps you could do that with RFA as well. But I do think we're in the era and area of immune-mediated treatment, and I think that there's probably going to be adjunctive therapy one day. We kind of rough up the tumor, and there's going to be stuff that can take it from there.
Yeah, Andy, that was a great presentation. Thanks, and thanks for the picture of the Avengers at the beginning. I really liked it. And the shout outs for Chris. That endoscopic hepatology book is absolutely tremendous. And I know he was really proud of it. And maybe those immune therapies, using plectin, that cell surface plectin that you're talking about at the end, as a way to direct things directly there is the way to go. My question had to do a little bit just with the RFA, because that is clearly the route to success here. So in terms of RFA in patients who've already had stents in, are there any concerns, interactions, something we would worry about?
So if they actually have metal stents, doing RFA through the metal stents, it's super safe. The metal stent kind of provides a barrier. You can actually PDT through metal stents as well, uncovered metal stents, that is, not covered ones, but you have to increase the power, and really the dosimetry gets a little haywire. No one really knows exactly how much longer, how much more intense a beam you need. But for tumor ingrowth, RFA is very safe through metal stents. Kind of our bias is we really reserve metal stents until the end, because we found that, you know, even if you have perfect metal stents, if patients live more than a year or two, they often become problems. And then, you know, we don't want our patients to be dying with these PTBD drains or multiple drains. And sometimes if you put stent through stent with an open cell stent design, even when it's ideal, it's hard to get at the stent that you've blocked off. And so we actually favor plastic stenting and repeated ablation, really until their functional status is poor, they can't handle more ERCP, they don't want more ERCP, and then we place the metal stents.
Yeah,
We have a number of, I think there's a few people who practice IBD here at Mount Sinai.
That's what I was going to say. That's
You
why we
maybe-
see so much.
Can you maybe give a spin on, you know, PSC related cholangio and perhaps maybe screening, developments in screening or best practices for screening these patients for cholangio?
Yeah, remind me about the second part, but PSC is interesting. You know, surgeons I've noticed, some of our surgeons have a little bit of bias transplanting patients with cholangio, using a good organ on a patient with cholangio because survival is not as great. PSC is an area where surgeons are more loath to do partial hepatectomies. And so I think that's an area where transplantation, and it kind of dovetails with the IBD and transplant hepatologists too, where transplantation is more viable. I think patients with PSC, their liver's not good, they have a cholangio, it's small, they're a kind of a key target. Now, with respect to screening for PSC, you know, I think it's a hotly debated topic. There are Mayo Clinic algorithms talking about once or twice yearly ultrasounds and CA19-9s. As we all know, ultrasound, EUS or transabdominal, very operator dependent. And so I tend to, the patients I follow, get yearly MRIs and CA19-9. But really that's not based on any data. And our hepatologists here who follow the bulk of the patients, half of them do ultrasounds, half of them do MRIs, but I think it's more style and art more than data. Can I ask what you guys do?
Well, I think it varies as well. I think here there's a tendency to do more MRCP and CA19-9s. I know a lot of these patients are managed by the liver. So, you know, in Mount Sinai, liver and GI are separate divisions, and then there's the whole Transplant Institute, which is separate from that. So I think in general, most patients are getting an MRCP and a CA19-9 every 6 to 12 months. That's been my bias. I think where it gets tricky is for patients with a dominant stricture. I find that some of our liver colleagues may be more aggressive with, you know, referring them to us for ERCPs and such. But my personal experience has been in a patient with a stable dominant stricture with normal LFTs, no fever, no symptoms, that I really avoid ERCP in these patients because of the risk of infection and pancreatitis, et cetera. And you know, unfortunately, I think it's a disease where I don't really know if we're screening as opposed to just catching early cancers. You know, it's not like we can identify some adenomatous equivalent in the bile duct on imaging or ERCP. We're basically going to find it when there's cancer. So it's not perfect, and hopefully there's some blood or urine markers that are coming down the road that can help stratify some of these patients. But no, I mean, I ask because it's a controversial area that there's a lot of heterogeneity in the management.
Yeah, actually, you just brought to mind a great thing to look at. Ross and I might look then at that population when this plectin imaging becomes a little more widespread. It may be a way to help, you know, corroborate what you see on the MRI. If it's hot on a, melded plectin image, maybe you're more likely to just pursue surgery, or maybe those are the patients we should investigate and sample.
Well, our time has run out. Again, want to thank you for visiting with us and taking the time to share your expertise with us. Always great seeing you, and look forward to seeing you at DDW in a couple of weeks, and looking forward to your collaboration with Ross and future studies that we can look forward to. So thanks again, and have a great day.
Thanks, you guys, been great hosts, and hope to see you in person soon.